I'd now like to move on and welcome our first keynote speaker, David Walsh, who is the director of the new Advanced Pain Discovery Platform, which is a very exciting new initiative funded by UKRI versus Arthritis and Eli Lilly and there's 4 new consortia, research consortia being set up, and a pain data hub. So I think the start of a new era in pain research. David has an absolute wealth of experience as a very experienced pain researcher based in Nottingham, and very much focused around arthritis and musculoskeletal pain. I'm delighted to welcome you, David, and I'm hoping that we'll have time just for a few questions at the end of your session. So if people want to put their questions in the chat during the presentation, then we can hopefully have a chance just to have a little bit of discussion at the end. Now, David, are you able to share your slides? Perfect.
Hopefully I am doing. I presume somebody's going to tell me in the chat if I'm not succeeding in this. So thanks for the invitation last year to present to SPaRC ASM, and again to this year. I'm looking forward to this meeting. I've been looking forward for over a year, let's put it that way. This is great. A lot's happened in the last year. So I'm going to be talking about arthritis pain, and I sort of set myself the title really of In the Balance. And it's through preparing the talk that I realised just how much of a balancing act chronic pain is, and arthritis pain. Here we go. So there's my declarations of interest. For time, I'll whiz through that. They're available for you. So what I want to talk about today is that balance between peripheral and central pain mechanisms. I want to talk about the balance between facilitation of nociception and its inhibition. I want to talk about the balance between pain and activity. I want to talk about that balance between symptom relief and structural damage, the balance between specific factors and contextual factors, and you can debate as to what is specific and what is contextual in this situation. I want to talk about the balance of the needs of the individual and the needs of our populations, and the balance between benefits and risks. So hopefully there's a bit of something for everybody in the audience. So Pain Centre versus Arthritis in Nottingham has been going for 11 years now, and we take an integrated approach to what is fundamentally a complex pathway. In arthritis pain, we're interested in the nociceptive drive from the joint, and particularly in osteoarthritis, been focusing on inflammation and osteochondral disease. We're interested in peripheral sensitization, which we now realise is a major part of osteoarthritis pain. We're interested in central sensitization at the level of the spinal cord. And you'll see on these sort of flash through slides how we take a forward and backward translational approach. Whatever we're doing is centered on the human lived experience of chronic pain. And we develop and use animal models to help us to better understand the mechanisms and to develop new treatments to then forward translate again back into humans. So many of the techniques that we use across species. We're interested in the role of the brain. We're interested in descending inhibition and facilitation. We're interested in things that are going on within the brain, functional, structural, and connectivity changes. And we're interested in how all these things interact with the context in which they're happening, the psychological context and the external context, and how all that together creates the problem of chronic pain. So starting with the joints and the nociceptive drive, I think there's a lot of evidence now that the 2 main pathological features in osteoarthritis which are driving pain are happening in the subchondral bone and in the synovium. So the subchondral bone on imaging is identified as bone marrow lesions, and in the synovium we recognize inflammation. The most obvious peripheral drive of pain in osteoarthritis is actually biomechanical. That's what our patients tell us. It hurts when I stand up. It hurts when I'm going up and down the stairs. That intermittent pain is an early feature of osteoarthritis pain. And it's only people with very severe and long-standing problems that tend to be describing ongoing pain at rest. And these things link together. So, for example, we recently showed that the bone marrow lesions, which are indicative of osteochondral pathology, are related to that biomechanical pain, in that it's the weight-bearing regions where those bone marrow lesions are most important, and their association with symptoms is with weight-bearing pain more than with non-weight-bearing pain. So the pathophysiological mechanisms that we're identifying, we can link to aspects of the patient's experience, both of which are complex. One of the approaches we've taken within the pain centre is a biochemical and histological approach, looking at joint tissues, looking at synovium and looking at the osteochondral junction. And we have, over the past 20-odd years, developed a fairly sizable biorepository of joint tissues from people undergoing joint replacement surgery and people who just died, so collected post-mortem. And inevitably, some of the people who die also happen to have osteoarthritis, and the people who are having joint replacements have a range of structural severities. And as our repository numbers have increased, and these are the numbers from 2014, so they're about twice that number now, there's a group in the middle where actually the people who died have the same sort of structural severity as a group of people who've had joint replacements for osteoarthritis. And I think it's reasonable to assume that somebody's having a joint replacement is more likely to have more severe pain than somebody who's not sought help for their knee pain. So it creates a matched chondropathy pairing where structural severity is the same, but the pain is different. So I've just explained that in a little bit of detail because there'll be a few bits of data through this talk that are using that comparison. So here's one of them, looking at what's happening in the subchondral bone in osteoarthritis. People with symptomatic chondropathy, so that's the TKR group here, have increased numbers of subchondral osteoclasts than people who have asymptomatic chondropathy of the same structural severity, suggesting that this bone turnover or the osteoclasts may have something to do with the link between what we're seeing as bone marrow lesions on imaging and chronic pain. And in fact, we can look at serum biomarkers. So this is TRAP, tartrate-resistant acid phosphatase. And somewhat to my surprise, the level of TRAP that's detectable by ELISA in serum is associated with the number of subchondral osteoclasts in the knee in people undergoing joint replacement surgery. And from what I'm saying, you won't be surprised then to find that TRAP5B in the serum is associated with osteoarthritis knee pain, both cross-sectionally and prospectively. This is work we did with Virginia Krause using the one of the cohorts from the States. Another subchondral factor that we've been interested in is innervation. So we know in neuropathic pain that cutaneous nerve densities are related to the pain that people describe. Now, in fact, the joint tissues are very highly innervated to start off with, and it's difficult to see changes in numbers in a tissue such as synovium. And it's probably more the quality of the nerves rather than the number of the nerves that's important. But in osteoarthritis, there are tissues within the knee joint which normally are not innervated that become innervated, and that may be a part of the source of pain in osteoarthritis. And one of those regions is at the osteochondral junction. And in the normal osteochondral junction, there are vascular channels that come from the bone marrow underneath the cartilage and grow into the non-calcified articular cartilage. And the density of the number of those channels and the frequency of sensory nerves in those channels increases with osteoarthritis progression. And here again, seeing this comparison between symptomatic and asymptomatic chondropathy cases, you can see that the percentage of channels at the osteochondral junction which are containing CGRP neuroactive sensory nerves is higher in those with symptoms than in those without symptoms. And we can model this within our animal models of osteoarthritis, and this is the meniscal transection model in the rat. And it's important to do this because if you're wanting to test treatments, novel treatments, and in this case we were testing TrkA inhibitor in animal models, you need to know that the model reflects the pathology which is causing the symptoms in real people, which it did. Synovitis. Synovitis is actually an early feature of osteoarthritis. So although it's associated with the severity of joint damage, it's not a very simple association. And there's a lot of discussion in the osteoarthritis field as to what the role of synovitis is. It certainly predicts progression of structural damage. But one thing is for certain, it's not restricted to end-stage disease. So here we're seeing people with early knee pain, people with established knee pain, 2 ultrasound indices of synovitis, synovial effusion and hypertrophy. And you can basically see the bars on the 2 sets of bars on the right sides of these graphs are higher than the blue bars on the left. So it's synovitis associated with pain in osteoarthritis. So there's undoubtedly a peripheral drive to osteoarthritis pain. And although as somebody with a research interest in pain, we've got very excited by central processes, it's important not to deny the peripheral drive to pain. I would say that everybody with musculoskeletal pain has a peripheral component to the disease. It's not the case that there are people with peripheral pain and people with central pain. And people with osteoarthritis, there is always a peripheral drive. Sometimes there's a large central component that's amplifying the pain, and sometimes there isn't. And part of our understanding of this is that one of the best treatments that's available in the National Health Service is arthroplasty. Joint replacement surgery for severe joint damage from osteoarthritis is very successful. So it's true that up to 20% of people still have persistent chronic pain that's problematic after joint replacement surgery, but turning that coin round, 80% don't. That's one of the most successful treatments we've got. Okay, so looking at why people don't necessarily have good responses to arthroplasty for osteoarthritis of the knee is one way of looking at, well, what are the drivers of chronic pain? And as you might expect, it's complex. There are a number of factors. So there's something about how well the pain control is preoperatively. And there's an important clinical implication there that we, just saying you're going to have a knee replacement anyway, it doesn't matter about your pain control, is neither ethically acceptable, nor is it likely to lead to best results. Comorbidities, body mass index, these are things that we know predict poor pain outcomes. More joint space narrowing predicts better pain outcome. In other words, less joint space narrowing, less peripheral drive in somebody with the same severity of pain predicts worse pain outcomes. Hip replacements tend to do better than these. So there's peripheral factors. And then there's these central factors. People with fibromyalgia do worse. People with sensitization, as indicated by quantitative sensory testing, do worse. People with poor mental health do worse. People who are catastrophizing do worse. There's undoubtedly a central risk factor here for arthroplasty. So here we have a good example of a treatment focused on peripheral drive that usually works, but unfortunately all too often doesn't. There's a lot more to know. If you put all these risk factors together, you can still only predict about 20% of the variability in post-surgical outcomes. So don't deny people treatment just because they're obese. They can still do very well. So what are those central pain mechanisms? Well, one way of looking at it is, well, what can we measure? And there's three broad ways that we've been addressing this. One is through self-report questionnaires, and I'll talk a little bit about the CAPNE questionnaire that we've developed. One is quantitative sensory testing, and there's three main types of quantitative sensory testing that we've found useful for indicating central sensitization in people with knee pain. One is pressure pain detection threshold. So the amount of pressure that's required for you to feel it as pain rather than pressure, not at the affected joint, because that will be affected largely by peripheral sensitization, but away from the affected joint. So for example, with the knee, we've been looking at tibialis anterior. Temporal summation, that increase in pain that people get with repeated stimulus, in this case a pinprick stimulus, is thought to be related to the spinal sensitization that we see in animal models. And then conditioned pain modulation. So this is about descending facilitation and inhibition of nociceptive signaling. So if you have one painful stimulus in your arm, then your perception of pain from a standardized stimulus at the knee will be changed, and usually it's decreased. That's often thought of as descending inhibition or release of facilitation. In some people, and particularly people with back pain and fibromyalgia, we've found that actually it can be increased. And then there's brain imaging, and brain imaging doesn't tell you what pain people have got. You ask people what pain they've got, but it's helping to unravel what the neurophysiological mechanisms are behind chronic pain and what makes people with chronic pain different to people with acute pain. So a little bit about central mechanisms traits. So my PhD student, Kahindi, spent her entire PhD trying to pull out what self-report items. Originally, she was aiming to find self-report items for peripheral drive and for central pain mechanisms, and there weren't any particularly useful ones for peripheral drive, and maybe imaging is more useful for that. But for central mechanisms, she found a number of items which were linked to PPTs, pressure pain detection thresholds, distal to the arthritic knee, so tibialis anterior. So the process is to read the papers to work out how we did it. But we've taken this forward beyond knee pain to be looking at low back pain. We've been looking at people with pain from multiple sources within our investigating musculoskeletal health and well-being cohort. And we're currently developing this with people with rheumatoid arthritis. So you can produce the central mechanisms trait, which is based on 8 characteristics. So these are characteristics of anxiety, depression, sleep disturbance, fatigue, widespread pain, catastrophizing, cognitive interference, and neuropathic-like qualities. Okay. And the factor analysis of those comes up with a central mechanism. And this is associated with a range of symptoms, self-management behaviors, physical activity. It has demographic associations, as you might expect. And importantly, it's associated with QST indices of central sensitization. It's associated with pain, as you would expect. It's associated not only with the affective component of pain, but also with the sensory component as measured by the McGill questionnaire. And it predicts pain severity under current treatment conditions. So, for example, people with low back pain undertaking pain management programs. So it predicts pain outcomes. In terms of imaging, the key factors in imaging that we've been pulling out as indicators of central pain mechanisms are connectivity changes within the brain. So early research on imaging looked at structure, and there are some weak signals of structural differences, that functional responses to acute stimuli. There are some associations with those, but when you look at the literature and systematically review, they're not very consistent. Things which seem to be most consistently associated with chronic pain are connectivity between different regions within the brain. So pain is a sensory and an emotional experience. And one of the things that seems to characterize people with chronic pain is that connectivity between centers in the brain which are involved in sensory perception and emotional centers. So here we're showing that medial dorsal thalamus connectivity is associated with negative affect in people with chronic knee pain, but not in people without chronic knee pain. So there's changes in the wiring within the brain. Okay, not necessarily hardwiring, and that's one of the good things about it, because this is potentially changeable, reversible. Going back to the periphery. So I've talked now about central and peripheral, and that balance, which varies between people. And I've mentioned that there are facilitatory and inhibitory pathways. And that applies both in the periphery and in the central nervous system. And here's some work pointing to vascular endothelial growth factor, which many of you may be aware of as an androgenic factor. VEGF inhibitors are used to stop abnormal vascular growth in the eye. Here we were looking in a semi-agnostic way at these two groups of joints, looking at the synovia, comparing symptomatic chondropathy cases with asymptomatic cases. And one of the big differences between the synovia that we see is that the symptomatic ones are more inflamed than the asymptomatic ones. So that fits with what I've told you earlier. When you go down to the molecular level, so this we've done, first of all, by RNA, looking at a panel of 96 messenger RNA species related to pain or inflammation. In the test group, we found associations with VEGF. In the replication group, the fold change was high, but it didn't reach significance, slightly small group, but the fold change is consistent there. And then we used Luminex to look at protein expression for VEGF-A, where again we found significant differences between the two groups. So it was pointing to us that out of these 96 genes that we were looking at, that VEGF-A may be an important driver, peripheral driver from the synovium for osteoarthritis pain. So VEGF it's an interesting molecule. Its expression in the tissues depends on alternative splicing of the VEGF-A gene. The alternative splicing produces little a isoforms and little b isoforms. And one of those is proangiogenic, increases blood vessel growth, and one of them is anti-angiogenic, it decreases blood vessel growth. And in fact, in animal models, we found that one of them, the pro-angiogenic one, increases pain, and the anti-angiogenic one decreases pain. So in fact, total VEGF tells us very little. What is important here is that balance between facilitatory and inhibitory molecules that are produced. So this is a replication of what I showed you from Laura's work, the asymptomatic versus symptomatic chondropathy, looking at all VEGF. And this is tissue sections looking at fractional area within the synovium, and the symptomatic ones have more VEGF. Nothing new there. If you look at the two A and B isoforms, you can see that the direction of the difference is opposite between the two isoforms. So that the symptomatic ones have a higher amount of the analgesic A isoform, and the asymptomatic ones have a higher proportion of the analgesic B isoform. Now, that balance in splicing depends on splice kinases, one of which is SRSF1. And you can see that there's a difference in SRSF1 expression in the synovium between asymptomatic and symptomatic chondropathy cases. And this is nice because this is a potential drug target. It's an enzyme. And so developing specific inhibitors of these splicing enzymes has the potential to shift from increasing pain to decreasing pain. Facilitation inhibition is happening in the central nervous system as well. And these are, the reference seems to have fallen off this. This is a paper under review at the moment from Dorothy Auer and their team in the Pain Center, looking at connectivity changes with the descending pain modulatory system. So this is periaqueductal gray connectivity. And you can see that this is complex, that there are differences between people with no pain and people with knee pain. The most important thing from this is that those connectivity changes change with the duration of pain. So that, they change according to whether people have QST evidence of high sensitivity or normal sensitivity. So here we're seeing a very plastic central nervous system in chronic pain, changes with disease duration, and changes which are linked to evidence of central sensitization. So let's take a step back from some of this more sort of scientific stuff. Whose pain is worse? So on your left, you've got Mo Farah, who in this particular year had to pull out of the London Half Marathon because of injury. And on your right, you've got somebody who's broken her ankle. And of course, we all know you can't tell whose pain is worse. But the point I'm wanting to pull out from this is that Mo Farah, as an athlete, will manage his pain so that he can perform in his races. In other words, if he's taking painkillers, he's taking painkillers to increase his activity. And the person on the right might do that as well. We don't know what she does. What she might be doing is immobilizing her joint and sitting on the couch, because if she doesn't move it, it doesn't hurt. In other words, she may well have reduced her activity. And she may rather do that than take painkillers. So here we've got a balance between symptoms and activity. And this is reflected in the Omerac-Torsi responder criteria for osteoarthritis. That actually you can't tell if somebody's responded by just asking them how much pain they've got. You need to take account as to what activity they're doing as well. So somebody may have less pain because they're not active, or they may have more pain because they're more active. Which is desirable? What's the goal? And this link, another sort of balance here that our patients have is that concern as to whether they're wanting to relieve their pain or whether they're worried that if they relieve their pain, they're just masking it. And this came out with the nerve growth factor story sort of very graphically. And I'll let you reflect on this as I go through. So John Wood, very highly esteemed, especially by me, neuroscientist at University College, nerve growth factor antibody treatments, which are very effective at reducing osteoarthritis knee pain, were first shown to be associated with rapidly progressive joint damage. His immediate interpretation, as with many, was, well, it's because you've relieved their pain, they're doing too much. And this is it's now really quite an old-fashioned, this is 11 years ago, it's an old-fashioned view of osteoarthritis pain. And it's linked into this idea that pain is caused by damage. And it's linked into the acute model of pain. Break your ankle, it's painful because it's damaged. But actually, the evidence behind this idea that using an osteoarthritic joint causes more problems is virtually non-existent. Yes, walking on an osteoarthritic joint is painful, so there's a problem in that sense. But does it actually cause damage? And this one is, there's a number of systematic reviews and original research articles that have come out over the last 10 years. And basically the evidence is that low and moderate volume runners have no more risk of developing osteoarthritis than non-runners. And there isn't enough evidence for high volume running. And you're talking about ultra runners here. My own gut feeling, but that's my bias, is that that's probably not going to be shown to be the case either. But that fear is still there. And actually, it's a fear that's increased often by clinicians who tell people that they've got wear and tear arthritis, who in one breath are telling them to exercise, and in the next breath are telling them that it's exercise that's causing the problem. So tanezumab, which is a monoclonal antibody that blocks nerve growth factor, consistently in the human clinical trials reduces osteoarthritis pain. And these are the pre-2015 studies that are showing effect sizes which are clinically important. You know, lots of ripples around this. This is major. There's nothing else like this. It's not perfect. And, you know, there's a lot of people who don't respond to tanezumab, and the people that do respond don't necessarily sort of go off back to normal lives with it. But this is a major step forwards. It's always the case with new drugs that the early studies are more favorable than you find in clinical practice. And of course, what you've got to compare with is what they might be having otherwise. And this is the last of the studies to be published, comparing tanezumab with non-steroidal anti-inflammatory drugs. By this stage, it's unethical to have a placebo group in there because we know it works. And you'll start seeing that these, you know, so these are people that are highly selected. So this, I believe, is probably underestimating the effect. But these effect sizes are not massive. They're still highly significant. And buried within those means, there'll be individuals who have very good responses. And you know, but NICE are currently considering whether this should be provided on the NHS or not. It's not a straightforward question, and it's particularly not straightforward because tanezumab was found to be associated with a rare complication, which has now been defined as rapidly progressive osteoarthritis. So in fact, tanezumab does not reduce the likelihood of having a joint replacement. And if anything, it might slightly increase it, but to what extent that's because people have worse symptoms or because they're in a research study and involved with specialist care and therefore can access it more easily, I think that's up for grabs. But the bottom line is that there is a real side effect associated with nerve growth factor inhibition, which is rapid progression of structural change. It's with a minority of people. Is that important? Is it unique to tanezumab? So this is what it can look like on the x-rays. It does occur in people not on treatment. That particular x-ray, in fact, is showing somebody who didn't receive the tanezumab before the structural change had happened. But you wouldn't know that. It has some similarities with the old story of analgesic hip. Actually, it has some similarities with what happens when you inject a joint with glucocorticoid. So this isn't unique to anti-NGF. I think there's an outside question as to whether what this is saying is that it'll be true of all analgesics. I really hope that is not the case, because I want to be able to relieve patients' pain. Or whether there are, as I do believe with the anti-NGF, very specific molecular pathways that involve nerve growth factor that are important for joint structural health. And I have my own theories about this, and I'm happy to talk about it offline. But I personally do not think that this is simply an analgesic effect. And part of the evidence that it isn't is that actually it's not the people with the biggest analgesic effects from anti-NGF who've had the rapidly progressive osteoarthritis. And it's not necessarily the index joint that's been affected. Okay, so this is probably an on-target in terms of molecule, but an off-target in terms of joint pain effective nerve growth factor. When we have a patient and we give them a treatment, the benefit that the patient describes is a balance of specific effects and contextual effects. We recognize that in clinical trials as placebo effects. And it's important to recognize with subjective outcomes like pain, actually, the majority of the benefit our patients get is contextual. That the NHS may recommend treatments that have a specific effect, which means the total effect is more than just the contextual effect. But it's still the case that on a one-by-one basis, the individual patient's benefit is mostly contextual. It's how we are interacting with the patient. It's the explanations that we're giving that back up the specific treatment that's important. And it's important to try and work out what that context is so that we can optimize it. One aspect of context that we've been interested in is anxiety. And again, in both rats and humans, we know that high anxiety is associated with higher central pain processing. Anxiety reduces analgesic response in both animals and in humans to opiates. And it's a risk factor for persistent pain after arthroplasty. So anxiety is an important part of that context. And it's not just about the pain experience, it's about what people do about their pain. So this is a community cohort, and you can see that higher anxiety is associated with more use of strong opioids. And it's important to recognize that although we do knee replacement for knee pain, and we use opioids for knee pain, okay, whether we should or not is another question, but actually just replacing the knee and eliminating the nociceptive drive doesn't take people off the opioids. We need to do more than that. We need to balance the individual against groups. And this is a multiple N of 1 trial that we did comparing 2 topical treatments for arthritis knee pain. Okay, and I won't explain the full protocol. Look that up in the reference. But the point of this was to try and work out individual responses. Small study, and as you might expect, with topical nonsteroidals or topical capsaicin, the mean effects are similar. No massive difference between the treatments. If you look at the individuals who responded to one rather than the other, there's a big effect. There's only 4 of these people who had a similar response to both treatments. So some people respond more to a topical nonsteroidal, and some people respond more to topical capsaicin. So just looking at these mean effects, which is what NICE looks at, doesn't actually tell you necessarily what you should be offering your patient. Can you predict it? Well, not very well. And it's probably trial and error is the best way of going forwards, but there is some suggestion that the indices of inflammation might predict better response to topical non-steroidal, and indices of central sensitization might better respond to topical capsaicin. And then finally, benefits and risks. So here's a quote from, sorry, it says Impress. This is actually from 10 years ago. Sorry, I haven't changed that. This man, 58-year-old man, I have to take painkillers, but I'm not a great advocate. I'm worried I'm going to end up with ulcers. It's like a merry-go-round. One thing goes wrong and all sorts of things follow on. That balance between relieving pain and the risk of side effects. And that is an individual decision. Yes, as clinicians, we need to decide where we're going to draw the line, but every patient is different. And this is some work we did in the US population that we've backed up now in a UK population, showing which factors associated with common analgesics, non-steroidals, and opioids, and the new NGF treatments are most important for individuals. And we might be worried about joint damage, but actually it's not the highest problem in people's mind at the moment. It might change, might that, but it's not. And when you look at these populations, we've done this with the UK population, there are subgroups. There are some people who are more worried about one thing and other people who are more worried about other things. There are some people who put more weight on pain relief rather than side effects, and some people who put more weight on. This is an individual decision that comes out of discussion. So to conclude, arthritis pain is a balance between peripheral and central mechanisms. It's a balance between facilitation and inhibition. People balance pain and activity in different ways. Symptoms, I would argue, can be more important than structure. The structure is important. Pain and analgesia result from both specific and contextual factors. Both are important and both are targets for treatment. Clinicians and healthcare providers do need to balance the needs of individuals with those of the population. And treatment decisions need to balance the individual's perspectives on benefits and risks. Thank you.
Excellent. Thank you very much, David, for a very wide-ranging and informative discussion there. There's a few questions in the chat, but we're running a little bit tight for time. So if it's okay with you, what we'll do is we'll send you the questions afterwards, so that we can get an answer to them. And I should say that as long as people give permission, we'll put the recording of today's event up onto the NRS website. Now, it's tradition that the keynote speakers get a gift from SPaRC and one of our coveted rosettes. So the rosette is here and will be in post along with the gift. That's what, so you should get that. So I think what we'll do is we'll just have a 5-minute comfort break and then restart in session 1. So you need to leave this session, which is opening session, and click back into session 1 in 5 minutes. But I'm sure everyone on their screens will join me in thanking you very much for a really fascinating and thought-provoking talk. Thank you, David.
Thank you, and I look forward to meeting some